Good morning to all. Thank you, Ramesh sir and AML and the team for this opportunity. So I'll be speaking on making expand quick and safe. It's a video. So recipient hepatectomy usually follows standard steps, be it easy or difficult, better to follow the same technique. Always anticipate difficult situations in easy expand as well. So preoperative imaging is mandatory in this case also as in any other case. Difficult recipient hepatectomy should be anticipated when there is a large liver following previous surgeries, prior SVPs, coagulopathy, when there is a caudate trap, presence of PVT, multiple collaterals at the porta, large caudate HCC and retransplant. So prior SBP, I would like to point out that often we have encountered very difficult situations following SBP. So that needs special mention. And in difficult situations, it's always better to get a suprahepatic and intrahepatic cable control and then a porta control. So we usually go with a reverse T incision. Good abdominal exposure is necessary. We use retractors. This is a pediatric explant where suppose Kasai where bowel was densely adherent. So as in any other case, we use sharp scissors. Bleeding should be controlled in pediatric as and when it happens. So moving on to the adult donor. So first we go for the triangular ligament division, then the suprahepatic cable dissection. We reach till the groove of the RHV and the MHV. Try to delineate that. Then the left lobe mobilization. Then going for the pars flaccida, where we sometimes we encounter replaced left gastric artery, left hepatic artery that needs division, and often we encounter collaterals also in this region which needs transfixation as well. So this is left phrenic vein which needs division and transfixation. We have encountered post-operative bleeding in many of the situations. Now we go for right hepatic, right lobe mobilization. After that, the inferior mobilization. After this, once the cava is seen, we need to loop the cava. So this is a critical step. The suprahepatic and the intrahepatic, once the cable control is there, then even if we experience any torrential bleed, then we can just, under total vascular exclusion, we can just take the liver out. So after that, we go for a retroperitoneal dissection, often ligate the right adrenal vein. We try to divide the short hepatic veins, and we move close to the RHV. So at this point, we may loop the RHV, but it's not a mandatory step. Usually after this point, after looping the infrahepatic cava, we usually go to the porta. Retroperitoneal dissection is very difficult. Often it can cause bleeds as well. So that one has to be careful there. Now we move to the callous dissection. Once callo is done, then we go for left hepatic artery delineation. So the initial days I used to be very careful when we encounter the artery. So I used to keep few tissues around the artery. These days, always Dr. Gupta used to say move as close to the artery as possible to prevent dissection. So these days we bear a tissue of left hepatic artery and then ligate. And in LDLT we usually have to go higher up into the hilum. Then we go for main portal vein looping. So once the main portal vein is looped, then the inflow control is also achieved. Then the right hepatic artery is divided. You can divide at the below, and you may go higher up also into the right and anterior and posterior arteries. Then we follow the left portal vein and we go to the left side, loop the bile duct along with some tissues. So in LDLT, it's always better to get right hepatic and left hepatic ducts as different, because often we encounter two ducts. Here, my colleague has used a cautery. I just cut with scissors with a bulldog on the bile duct and the tissues. So you may use cautery, but personally I feel it's better to use scissors. Then we go for portal vein lengthening. The tissues are divided, the small veins are ligated, so that we get a good length of portal vein. Now once we have achieved a good length of portal vein, then we go for anapatic phase. So this time should be recorded because it's important, the anapatic phase. So here we divide below the division of the right and the left portal veins, because we use the portal vein for our new MHV creation. You may suture the stump. Initially we used to stitch, but as you gain experience you can avoid this step. Then we go for inferior hepatic vein division. If it is large, it's always better to use Satinsky clamp and suture. Better not to apply clips because multiple manipulation might result in bleed or slippage of the clips. So again, inferior phrenic veins are divided. It's always better to divide and suture fix phrenic veins because we have experienced post-operative bleeding on day one, just after extubation. When the patient was extubated, they cuffed and it bled, and when subsequently we found that it was just bleeding from the phrenic vein. So now the liver is just held up with the hepatic veins. So the hepatic vein, we try to deline the right hepatic vein. The tissues can be divided with cautery, or if veins are there, it's always better to suture, not to apply clips. Better not to apply clips close to the RHV side because this clamping, the clips may, might come in between the clamps, so that might be difficult. So here in this point, we lengthen the RHV so that we get good stump of the right hepatic vein. And after division of the right hepatic vein, the liver is just held by MHV, and obviously the caudate part would be taken care before that. Now it would be held only between the MHV LHV complex. It's always better to get a good stump of MHV because in our unit we use MHV LHV complex for the new MHV reconstruction. So once this is done, the explant would be complete, and after the explant, the explant is complete. And after we close the MHV stump temporarily, and after that we go for portocaval shunt, temporary portocaval shunt. So temporary portocaval shunt, the hemodynamics are better. We get time for hemostasis. Thank you. So I didn't say this before because I may run short of time, so that's why. So I would like to thank Ramesh sir, Sindhu ma'am, because whatever I am today is because of them. When I initially went to Delhi, so I was very apprehensive. I thought, there were students like from AIMS, GB Pant, whatever. So I felt very I was too underconfident. But subsequently, I knew that the training which I got from Thiruvananthapuram Medical College by Ramesh sir was exceptional. I gained confidence. I really would. He is my mentor. I would like to thank sir. And Sindhu ma'am, I was very happy working with her. I still remember she gave me my life's first skin to skin. Yeah, now it's skin to skin Whipple. She has taught me a lot about minimally invasive surgery. So, and one more person, Raviram. So he was my first teacher when I joined MS. So he was my surgical trainer at that time. So special thanks to Raviram also. He taught me minute things which I still follow. So thanks a lot.